Welcome to the PETAL Podcast. PETAL Consortium is a global network of more than 100 investigators from over 20 international medical centers that are dedicated to advancing care and research for patients with peripheral T-cell lymphoma. In this series, we will explore topics related to peripheral T-cell lymphoma to help guide healthcare professionals when caring for these patients with rare and aggressive blood cancer. Hi everyone, I'm your host, Dr. Salvia Jain, a hematologist-oncologist at Massachusetts General Hospital in Boston, USA. In today's episode, we'll be discussing the classification and diagnosis of patients with mature T and NK cell lymphomas. Joining us today are Dr. Carrie Weyden, a clinical hematologist at Peter Mac Cancer Center in Melbourne, Australia, and Dr. Basem William, a hematologist and a bone marrow transplant physician at OhioHealth in Ohio, USA. So Carrie, welcome. How common is PTCL? And given the 2022 WHO classification, how should oncologists think about major subtype groupings without getting lost in the complexity of 30+ entities?
Thanks, Salvia. I think it's important to recognize that peripheral T-cell lymphoma is rare across the spectrum of all cancers. Amongst lymphomas, they're definitely less common than B-cell lymphomas, and they comprise about 10 to 15% of all new lymphoma diagnoses. But that's still quite a large number of cases across the world. So in the US, that's up to 12,000 new cases per year. In Australia, where I work, it's up to 500 new cases that are diagnosed every year. And then the next thing that we think about is that those numbers actually encompass a wide variety of different T-cell lymphoma subtypes, and that encompasses the spectrum of indolent, more slowly growing lymphomas, all the way through to very aggressive, quickly growing lymphomas. And overall, the latter group is much more common across PTCLs generally. The challenge that we have as clinicians is that the complexity of how we think about those diagnostic groupings changes year on year. And part of that is to do with the fact that our understanding of the clinical laboratory features of those subdiagnoses is improving. That being said, it can be overwhelming even for people who've been practicing for years. What I think about is that there are broad groupings that really hold true over different iterations and updates to the way that we think about classification. There are those that are predominantly nodal in presentation, those that tend to present with more extranodal manifestations, those arising in skin, and those that predominantly have circulating disease in blood and bone marrow. And I still think about those subgroup families when I'm talking about how do I conceptualize PTCL when I'm teaching my students or junior hematologists, for example.
Thanks so much, Carrie. Basem, anything to add?
Thank you, Salvia. Yeah, I think I agree with Carrie. I think the key for community oncologists is not to get overwhelmed by the complexity of the WHO classification. Clinically, it's more useful to think about PTCL in broad biological buckets. Nodal diseases like PTCL, NOS, angioimmunoblastic T-cell lymphoma, and ALK negative ALCL, extranodal entities like ENK T-cell or hepatosplenic T-cell lymphoma, and leukemic presentation, and CTCL and other T-cell lymphoma, primarily involving the skin. What's become increasingly important is that these are biologically distinct disease with a very different molecular drivers, prognosis, and potentially targetable vulnerabilities. So even though there are more than 30 entities, recognizing that PTCL is not one disease, but a family of rare diseases is probably the most important conceptual shift.
Thanks, Basem. Another question for you along those lines. What are the key clinical features or presentations that should make a community oncologist suspicious that they may be dealing with a T-cell lymphoma rather than a more common B-cell lymphoma?
That's a great question. One major clue is disproportionate systemic inflammation. So patients with T-cell lymphoma often look much sicker than the bulk of the disease would suggest. They may have high fever, profound weight loss, diffuse rash, eosinophilia, autoimmune phenomena, or marked kind of disabling constitutional symptoms. Other clues: immune dysregulation, cytopenias, elevated ferritin, liver dysfunction, or a frank hemophagocytic presentation. Unexplained inflammatory markers would raise this kind of concern. Clinically, extranodal involvement is also more common in T-cell lymphoma compared to B cells. So, skin, liver, spleen, bone marrow, GI tract, and some patients present almost like severe infection or autoimmune diseases rather than a classic lymphoma picture. So, a high index of suspicion is needed. Importantly, if a presumed reactive process keeps behaving aggressively or atypically, T-cell lymphoma should stay on the differential.
Thanks, Basem. Carrie, any further thoughts?
I think Basem's really articulated the key points here really thoroughly and precisely. The only other additional point that I would underscore is that it's really important to have a high degree of clinical suspicion that a patient might have T-cell lymphoma, particularly if their clinical presentation is atypical. Features like autoimmune or immune-mediated phenomena and really profound systemic features often are the hallmarks of these diseases. And so in that setting, it's really important to thoroughly seek a tissue diagnosis. And for clinicians, it's also important to recognize that that may not necessarily be from a nodal side.
Thanks, Carrie. So, Carrie, how quickly can patients with PTCL get sick? That's one question. And two, could you further elaborate on the complex presentations of PTCL mentioned, such as hemophagocytic lymphohistiocytosis, autoimmune cytopenias, Epstein-Barr proliferation?
Good question. The first thing to say is that we recognize that there's no such thing as the prototypical or the usual peripheral T-cell lymphoma patient presentation. There are some patients who have a very subacute evolution of their symptoms, and that can be over weeks to months. And that's particularly, for example, in some cases of things like T follicular helper phenotype lymphoma, of which angioimmunoblastic T-cell lymphoma is the canonical diagnosis that we observe. On the whole, though, I think that presentation is less typical. And the more common pattern that I would see in my patients is that there's an evolution of symptoms and signs over weeks rather than months. As Basem's outlined, the manner in which patients present can be with a predominance of inflammatory and systemic symptoms, and that can change acutely, and that can be over days. And so the other pattern that I would see in my patients, independent of that sort of systemic inflammatory presentation, is patients who present with local complications that can be from a lymph node or an extranodal mass, and those patients present often with pain or organ dysfunction. I think the other thing that you've alluded to in the second part of your question there is that one of the more challenging ways in which PTCL can present is due to disturbances of the immune system. And that can either be an oncogenic driver of the lymphoma in the cases of some sort of viral etiology, of which Epstein-Barr virus is the one that we most commonly observe, or again, more commonly, this is a reflection of the manner in which PTCLs upset the balance of the immune system. And so the first group that I would think about is groups of lymphomas which are driven in part by that virus called Epstein-Barr virus, EBV. And as part of the lymphoma presentation, those patients often present with a pattern predominantly of symptoms like fever, night sweats, fatigue, weight loss, and they may or may not have a high volume of enlarged lymph nodes or an enlarged liver or an enlarged spleen. And that's also seen in patients who've, for example, been recipients of a solid organ transplant, and can be seen in patients who come from areas of the world where ABV is endemic. It's important to recognize that we can also see that de novo in patients who have the immune system disruption that's very key in T-cell lymphoma. The other group where we think about immune dysregulation as a marker of the way that PTCLs behave is fascinating for me as a clinician, but also personally terrifying because of the rapidity with which these patients can get sick. And what we see in that group of patients is that the T-cell lymphoma is driving the immune system to be hyperactive or overactive, as well as being very imprecise and unfocused in the way that it behaves. And so the classical manifestation of that can be autoimmune phenomena, such as immune-mediated changes in blood counts, but diagnoses that include paraneoplastic neuropathies, rashes, very commonly seen in angioimmunoblastic T-cell lymphoma, for example. The most extreme and sort of challenging complication of this process is HLH, or hemophagocytic lymphohistiocytosis. And in that syndrome, the immune system is catastrophically activated. We see that the patients have profoundly high inflammatory markers, including ferritin and other acute phase reactants, and that process results in the profound consumption of blood cells and clotting factors and leads to multi-organ dysfunction from which the patient will become critically unwell. The thing that I recognise as a clinician is that can develop hyperacutely, and if it's not identified and treated early, can actually become self-perpetuating. And unfortunately for our patients, even with effective treatment, it has a very high mortality rate. So one of the things that I talk to my students about and the two other junior clinicians is that if you see HLH developing in an adult patient, I always question, maybe it's my bias, but always question whether T-cell lymphoma diagnoses have been actively sought and excluded.
Thanks, Carrie. Basem, what is your preferred diagnostic workflow when you see a new patient with suspected mature T and NK cell lymphoma?
Yeah, my approach starts usually with obtaining enough tissue and usually mean an excisional biopsy whenever feasible. Right now, I think the standard have shifted to doing cores on everything, and as lymphoma clinician, we know what is the danger of core. That message had not gotten across to our surgical colleagues. Cores are usually very insufficient because we lose the architecture, we use a tumor microenvironment, which are critical in a T-cell lymphoma diagnosis. And beyond routine pathology, I'm a strong advocate for expert hematopathology review. I think is very key. That includes comprehensive immunophenotyping, flow cytometry, ABV testing, and molecular study. T-cell receptor clonality is very useful, and also I pretty much run an NGS on all of my patients. I might be wasting a lot of money, but I think it's well spent. Staging would typically include a PET-CT. Bone marrow evaluation is standard in almost all cases, and careful assessment for inflammatory complication like HLH. Importantly, I would say diagnosis should not be rushed because of limited tissue. If necessary, I use steroids to stabilize a patient, or occasionally I might give something like etoposide if I'm dealing with HLH, but misclassification is common and accurate diagnosis is critical to provide a good decision for management.
That makes a lot of sense. Thanks, Basem. Carrie, question for you. At what point do you think a community oncologist should refer a patient, if at all? And while that referral is being arranged, is there anything a community oncologist should or shouldn't do in the interim?
Thanks. In my opinion, early referral is always better. In our local practice here in Australia, we emphasise that it's important to be both consultative and collaborative, and that's mostly because we recognise that these disorders are rare, that they can present in very atypical fashions, non-standard fashions, and that approaches to best management are particularly nuanced across the spectrum of the different diagnoses that we can see in clinic. I think expert advice should always be sought, but that can be as simple as discussing it with a local expert team or presenting the case within a multidisciplinary forum to seek diagnostic clarity as well as to discuss approaches to management. Ideally, I think a referral should be to a centre or a specialist who has expertise in diagnosing and managing T-cell lymphoma, and part of that is not just about approaches to management, but also making use of the expert multidisciplinary team who have resources that sit behind what you see in the clinical space. The other thing that I would counsel is that ongoing management doesn't have to necessarily be at that quaternary referral center, and that management can be done locally in partnership once the relationship's been established. With regard to the don't do's, the only real thing that I counsel against is to emphasize not waiting until the patient's critically unwell, or hesitating, for example, to pick up the phone for some input when the case is diagnostically unclear. And that's particularly a challenge for some geographically isolated practitioners or rural practitioners, and that's especially true here in Australia, and I assume also the case in the United States. I think no community oncologist should fear asking for advice from a tertiary or quaternary referral centre, and that applies even in settings where you haven't yet established the diagnosis but have a high degree of suspicion that you might be dealing with a T-cell lymphoma.
Thank you, Carrie. That was very helpful. Basem, anything you would like to add?
Just to emphasize what Carrie has said, these are rare diseases, and early specialist involvement does genuinely make a difference. I would emphasize or strongly emphasize that community oncologists should feel comfortable referring early, even before the full workup is complete. One practical point to add is avoid prolonged empiric steroid before biopsy whenever possible. This is true for both B and T cell lymphoma, because that can partially treat the lymphoma and compromise diagnostic yield. The other point is urgency. Some PTCL can evolve very rapidly, especially the histologies that are associated with HLH. Patient can destabilize very, very quickly. So early referral sometimes does make a big difference in those patient outcomes.
That is very well reasoned. Thanks, Basem. Final question to you. What's the single most important thing you want a community oncologist to walk away after this episode?
I think the biggest takeaway is this: mature T and NK cell lymphomas are fundamentally different from B cell lymphoma, biologically, clinically, and therapeutically. They are rare, heterogeneous, and often highly inflammatory disease where early recognition, adequate tissue acquisition, and expert multidisciplinary evaluation is essential. And also, despite historically poor outcomes, the field is evolving rapidly. We have better molecular understanding, we have novel targeted therapies, we have evolving cellular therapies, we have international collaborative effort like PETAL. So it's not necessarily a waste of resources to send the patient early because they're gonna do poorly anyway. I don't think that's still is true in our days. We can make a difference if we receive the patient early.
Thanks, Basem. Couldn't agree more, and very well justified. Carrie, anything to add?
I'm completely aligned with what Basem said. I would just add a couple of extra points. I would encourage listeners to think about the possibility that the patient sitting in front of you might have peripheral T-cell lymphoma if the clinical and laboratory features don't seem to make sense in that traditional lymphoma diagnostic model or in a broader sort of oncology spectrum. My second comment is that my personal experience is that T-cell lymphoma clinicians are collaborative and helpful, and that asking for advice and referring patients for an opinion about diagnosis or management is always welcomed by those of us who work in the area. And my final comment is really to echo Basem's statement, is that there's no need to be nihilistic about this group of patients. So I personally have seen how quickly the field's evolving in terms of seeking to refine and deepen our understanding of this group of diagnoses. And this really has the potential to transform how we define optimal approaches to treatment and to design precision therapeutics that will, we hope, deliver better outcomes for our patients.
Amazing. Thank you so much, Basem and Carrie. This was lovely. Thank you for joining us today and for sharing, wealth of wisdom with all our viewers. Thank you, everyone, for listening to our first PETAL Podcast episode. This podcast is sponsored by Secura Bio and Corvus Pharmaceuticals. For more information about peripheral T-cell lymphoma, please visit the PETAL Consortium's website at petalconsortium.org. We appreciate you tuning in. Have a great day, and we'll see you next time on the PETAL Podcast.